Okay, I think the theme for today is bald guys who are recently have been in Mexico or are about to go to Mexico. Because I'm just back, Del Donald is on his way, and we're both bald. So the other thing, I think what we're going to try to cover in this second session is a little bit, Del talked to you a lot about carrots. And I'm going to talk to you about carrots and sticks. But hopefully you're still going to see that there's still more carrots than sticks in my presentation as well. So I'm going to use a little bit of different language. And feel free to jump in at any time if you have questions. But we're going to cover, instead of harm reduction, we're going to be talking about mitigating risk. Okay? So we're going to still be talking about the same kind of principles, but we're going to have a little bit of a shift in our thinking. And what I'd like you to do as you're hearing the talk and as you're thinking about the different scenarios I'm going to pose to you is think about what your personal feelings are about a lot of the methadone patients, the cocaine-using patients, the OxyContin-using patients who you've seen, and think about how your personal feelings towards those people really influence the way you interact. So I'm going to cover a little bit, just a tiny brief introduction. Some of it may be very similar to what Del talked about. Unfortunately, I really wanted to avoid slides, but I think my trip to Mexico may make me rely on my slides a little bit because I still may have some slight tequila poisoning. But the big thing to know is that NAS cases have dramatically increased in the province. Okay, we've gone from seeing this, and you could see it quite nicely from the numbers that Del put up. There's been a big upswing. And we know that the number of Ontarians in methadone maintenance treatment programs has risen from 700 for the whole province to 16,000. Okay? And that 16,000 is 3-year-old data. So that number is continuing to rise and rise. I recently saw a number of 26,000. And that may be a little bit more of an accurate figure. We're looking at about 5% of all pregnant women who are using drugs. Okay? That's probably a conservative estimate. Some of the estimates in the U.S. say up to 13%. Now, how many go on to develop neonatal withdrawal? You're probably looking at more like 5 in 1,000. Okay? But that number has risen from about 0.8 per 1,000 a decade ago to almost 5 per 1,000. So a dramatic rise. And to put that into a little bit of context, it's about 2.9% of all NICU admissions, but they take up about 20% of all NICU bed days in the province. 20% of the resources. Okay? This is a huge issue. And I would say that this is probably the number one issue that's currently affecting our departmental budgets. Okay, we're having to figure out budgets and budget cuts and all that kind of stuff. Just had a meeting on it. This was the big elephant in the room, okay, that is going to drive policy, drive dollars, and drive jobs. Okay? So what we're going to be trying to talk about, and hopefully I'll get some input from you as a group, is trying to figure out different ways of doing things that are safe, okay, or safer. I don't want to use the word safe. That are safer that promote better bonding, that promote better outcomes, and that try to reduce risk wherever we can. Now, Dell talked about how there are a lot of rules as to what he can do, exactly how much he can prescribe, when he can prescribe it, depending on the types of drugs that a mom is on, what he's allowed to do in a circumstance of benzos with methadone, he's got to lower it up. So that is a very kind of concrete thing where people can expect a little bit of clarity from one patient to the next. So any mom who's going into an MMT program can typically expect they're going to be treated about the same. Okay? Now, it might not be identical. Doses are going to vary. Everything's individualized. But there's a framework. The biggest problem with the baby side of things is that there is no clear consensus. Okay? So there is no clear consensus. If we were doing this talk, and I was talking to you from Arizona, okay? I went on a great fishing trip to the Grand Canyon, did my fly fishing in Arizona. I don't know if I would want to live there, okay? Because what they say is any mom who is using a substance that a baby withdraws from, you have to report to the police. Not CAS. Criminal report. So, and that includes anybody on methadone, anybody who's using anything. You withdraw, you get reported to the police. Okay? And CAS. And so, and then once the baby starts the withdrawal process, they have to spend the entire time in the hospital. So it's very criminalized type of environment there. We live in a different environment. Dell was talking about the fact that we have more community-based treatment programs. We're trying to do more things with methadone. And therefore, we've also become a little bit of a leader in North America in trying to develop different protocols and figure out a way through this nebulous cloud of there's 400 different ways of doing things. Okay? So we're going to talk a little bit about that as well. It is an evolving field, and it is very individualized. Okay? So I just to make things very simple, because I like to make things simple to teach the processes, or this is not a blanket statement, but if you take Toronto and you draw a line through it in the province, everybody east of Toronto says, we're going to keep them in hospital the whole time, we're going to keep them for 6 weeks, nobody goes home on morphine, and that's just the way it is. And then west of Toronto, the general tendency is to say, keep them in hospital for about 2 weeks, send them home on morphine, everything will be okay. And guess what? Both places are probably right. There is a big split, but there are also some things in motion now where I think it's that evolving field. And we'll talk a little bit about that. So hopefully today we'll do some collaboration to figure out strategies to implement that could promote bonding. We can do some strategies to promote risk reduction. And we'll help try to identify some of those risks. So what is NAS? What does it look like? It's really just a constellation of symptoms. So there's no kind of specialized lab test you can do. It's a constellation of symptoms in an infant who's withdrawing from the in utero effects of a prescription or a non-prescription medication. So it could be methadone, it could be nicotine, right? It could be an SSRI like Prozac or Paxil. Okay? Those can all give you withdrawal symptoms. So part of my talk, Del was talking a little bit more of a pure group of patients. Some of the things I'll be talking about are going to cover other drugs and trying to look at that as well. So what does it look like if we get into a little bit more specifics? And this is all going to be available electronically, so don't feel you have to write down all sorts of notes. But there's 3 basic areas: CNS, so your neurologic system, the metabolic, vasomotor, and respiratory systems, and then GI. So abnormal cry, these are the colicky kids, right? But like colicky on steroids, right? These are very colicky, pronounced startled, they're highly agitated, they're very hyper alert. They have that increased tone. They may scratch themselves to the point of bleeding. They may be really jerky, right? And just anything will just make them have these big jerks. And at the extreme, they may go into even generalized convulsions. Okay? Metabolic, sweating, fevers, mottled skin. They just don't look well. They might have really bad nasal congestion because they're just having lots of secretions. Sneezing, nasal flaring, and breathing difficulties where they're actually indrawing to the point where they look like they're really working hard to breathe. And then GI disturbances where they're sucking excessively, like sucking on their thumb to the point of no return. Poor feeding, regurgitation, vomiting, and diarrhea. I thought of making diarrhea like the biggest word on the page, but we find that that's a really big component, and it actually does really affect your management plan quite a bit. So what is mitigation? Mitigation is making something less severe, serious, or painful, so you wanted to mitigate misery in the world, or lessen the gravity of it. And a way to think about risk mitigation, okay, versus harm reduction. Risk mitigation is like driving a car, right? So how many of you today, wore your seatbelt in, right? Everybody wore their seatbelt, probably. That's a way of mitigating risk, right? But when we think about all the things in the system that help us drive safely, you've got to think even farther than that. And there's things like the road design, the way the surface is, the lines, the barrels when we're going under an overpass, barriers, car design, and all the engineering that went into that, and the frames, the airbags, the seat belts, the way the glass is, car seats, road laws, speed limits, the fact that I expect the other guy to stay on his side of the white line. There's all sorts of things that go into mitigating risk while you're driving. So I just went to Mexico. How did I mitigate risk for my family? I made sure they had their travel vaccines. I made sure I had a professional driver. I didn't rent a car when I was down there. We wore our seatbelts on the bus going from Cancun down to the resort. There were 2 fatalities on that trip. It's a notorious highway for having a lot of really bad accidents because a lot of the Mexican drivers like to drink and drive. So we were warned about that. So those are all risk mitigation things you can do. And then you watch what you're eating while you're down there and all that kind of stuff. So, it's like, what are we talking about with NAS, right? After all, what could possibly go wrong when we're dealing with these patients, right? It should be easy peasy, right? We should be able to just glide through everything. And we all know that that's not the way that it works. But I like the term risk mitigation rather than risk elimination. Because at the end of the day, and I know all of you are dealing with these people, each and every one of you is going to make a decision that's going to involve some risk. Okay? I'm not a magician. I can't pull the rabbit out of the hat and make the risk go away. So don't fool yourselves into thinking that you can do it and be absolutely sure that nothing will ever go wrong, because you're not going to be able to. But you can make wise decisions to try to help the mums who you're dealing with. So, any questions so far? Okay. So, there's basically the 3 time frames. So, it's fairly straightforward as far as what times we have to intervene with mums who are at risk for having a child with neonatal abstinence. So, prenatal, perinatal, and postnatal. So the prenatal kind of risk factors, and Dr. Donald touched on it, family planning and birth control, okay, is huge. Huge. And I know we talked about it a little bit as far as family planning and use of birth control. The way one mom described it to me, she said, when you're an addict, okay, and you're on OxyContin, and you're using these high amounts, you're often going to become amenorrheic, okay? She didn't tell me that, but I knew that. You stop having your period. You stop having a lot of sex drive, okay? You feel like crap. You're not eating well, right? And what happens is when you start methadone, you feel great. A burden is lifted off your shoulders. You start to recover. You start to gain back interests that you've lost. And one of those interests is sex. And she says she knew so many people, including herself, who had gone on to treatment and without really thinking about it, oopsies, were in that situation. So one of her suggestions to me, she said, if you're ever talking to people about this, you make sure to drive home to them the importance of promoting some sort of family counseling type of information. Okay? Case identification. Sorry, question in the back.
Does methadone affect your birth control? Like, you know, when you're on certain birth control, antibiotics can affect that? Would that happen with methadone?
As far as I know, no.
Okay.
That's a good question, though. Other people in the audience may be more expert than I am on that.
It's not, it doesn't really affect your birth control per se, but it does increase your fertility. As a woman, it decreases the testosterone in men, but it increases the fertility in women.
Yeah. I think getting your period back and starting to cycle again is probably the biggest effect that it'll have on the fertility. Because yes, it does those things to the hormones, but when you're talking about the living experiment of a person, I think actually getting your period back is a huge thing. Okay, case identification. So in the current Ontario guidelines, they talk about doing the birth control talk, identifying cases. Their suggestion is to follow the SOGC guidelines on identifying these mums, which means every single mum who's pregnant needs to be asked about cigarettes, alcohol, drugs. You do a universal type of screen, and then where appropriate, you offer screening for other drugs, or you identify those who might be at risk for other drugs. Okay? So case identification, when they've looked at patient populations, some places at one point were recommending every single person have random drug screening. That's kind of, it's not always possible to do in a general population. You can get people very staunchly opposed to having their rights violated like that. But I think trying to identify cases has become better and better and better over the years. One of the reasons I think that we're seeing so much more neonatal abstinence is we're just smarter, right? I don't think we looked for it enough 10 or 15 years ago. So one of the things, this has become a hot topic because they're eating up 20% of all our neonatal beds. Well, now people are starting to say, hey, let's identify these folks and let's figure out what to do with them better. So you can do addiction management, good obstetrical care, minimizing a lot of the prenatal risks, early pediatric consultations. That was one thing I wish Dr. Donald's slide had was something that said how many people saw a pediatrician before they gave birth. At our center, we try to do pediatric consultation for every single mom who is going to give birth. So I think that that's valuable because then I can tell from my perspective, because I'm going to be the one who's taking care of the baby, what the mom should expect, what the length of stay is, what the department is looking like at any given time, and give them a little bit of a heads up as to what to do. Up until recently, they were recommending that CAS be notified about every single case. So any mom who was deemed at risk for neonatal abstinence was to have a CAS consult. Okay, it's not like the same kind of notification, but in a proactive way, what the CAS consult was meant for these moms is, in my mind, it was a way of ensuring that the home was safe, that somebody had gone out to the home and taken a look, and that was one of the criteria for being allowed to go home early with the baby. Okay? So, again, it depends on your perspective here. Some people would feel automatic CAS involvement is too intrusive, and I think that's a valid point. On the other hand, if I don't have that CAS involvement to really say, is this a safe home to go into, then I'm going to say, okay, I got to keep the baby here the whole time for the 6 weeks. And in my mind, there's a process that you can have with a parent to say, look, our department policy is CAS notification on everybody. Please don't think of this as being punitive. It's not meant to be. This is to help you go home earlier with your baby. Okay? Now, I'm sure that's going to raise some questions. So let's talk about that.
I'm helping babies, healthy children, and when I visit a mom that's pregnant and she's on methadone, I will say to them, there's a high likelihood that when you have the baby, CAS will become involved. So I often encourage them to call CAS themselves or while I'm there, so that they get that process going ahead of time, so it's not such a huge shock when they go to the hospital.
And that's absolutely one of the, if you want to use the word benefit, of having CAS involved prenatally, is so that we're not getting that call from the hospital at the time of birth, and really probably it feels much more intrusive to have CAS on an unplanned basis at the time of birth when you're already struggling or challenged by many other issues. It's nice for us to have met ahead of time, talked about a plan, and done some of that work ahead of time.
Anybody else have thoughts?
Sorry, it's not highly likely in this hospital that children say will become involved if you're on methadone. So don't use highly likely, say they will.
The one thing, though, if you read the provincial report that was published in November 2012, they actually specifically say that if a mom is stable and on methadone, it should not be considered a criteria for notifying CAS. But that's our internal policy.
Yeah, that's
when we're talking to the whole group, the provincial guideline says that you really don't have to. Our department, and that's where I was trying to get at, our department feels that it's important. I feel that it's important. I would rather, before the fact, say, hey, I have a mom, she's been on methadone for 2 years. She's got all her carries. Her risk has been identified as being low by BMC, and I'm giving you a heads up that she's going to be delivering at some point, because it's not only me who has to make that decision. Every single person who sees that mom afterwards is going to be making that exact same decision, right? So I want to protect that mom, right, also from having somebody at 2 o'clock in the morning call CAS unexpectedly and say, I have a mom who's using methadone and she's, a crackhead and whatever, right? You want to, I like the way Dell described that. He said it's almost like an immunization, right? It's that making sure you can smooth out those bumps before you hit them. Okay, and I think that's where working in collaboratively really makes a big difference. So perinatal risk factors, prematurity, stillbirth, hepatitis B, hepatitis C, HIV status. We're lucky that in this region, Hep B and HIV are not extremely high, even in our methadone populations. Hep C is a big issue, okay? And it affects somewhat the breastfeeding decisions. So that's why I have it there. Sexually transmitted infections, which may be higher in this population, depending, again, if we're talking about MMT or if we're talking about somebody who's a polydrug user who's just coming in and hasn't declared themselves, right? Okay, so postnatal risk factors. And this is where I think we're going to spend the most time. But things like, and think about your individual circumstances, how good are you at keep making sure that the babies don't get separated from the mums? Okay? How often is, well, if we're doing NAS scoring or we're worried about it, it needs to be done in a different area? Or can that be done in the mom's room, in the usual postnatal or postpartum unit? What is the breastfeeding support like? So I was actually very encouraged. That actually is the first time I can remember seeing that data from Dr. Donald. But I was very encouraged by our very high rates of breastfeeding moms at 3 months. That figure, he said, I think it was 33 or 35%, that approaches the national average for non-methadone moms. Okay? We locally have very good rates compared to the national averages. So our breastfeeding initiation rates are somewhere around 85%. By 6 weeks, it falls off to about 50%. And then it tails off at 6 months. Locally, our breastfeeding rates are at about 35%. Okay? So if this methadone group can still be breastfeeding at about a 30% rate, I would congratulate everybody here and those moms because they're doing an awesome job. Okay? Most studies say that patients who have babies who go through neonatal withdrawal have about a 15% rate of breastfeeding at 5 days. And that it falls off to about 5% by about the second week. Okay? So, now, again, that's all comers. That's not just methadone moms in those studies.
I was just going to say, sometimes in the beginning, too, it's good to get these moms pumping because the babies with their excessive sucking and their poor feeding, they're not necessarily good breastfeeders with the poor feeding, or they'll basically chew the mother's nipples off. So sometimes nipple shields are good, and getting the mom pumping until the babies kind of do get better at feeding, and then they can transition to the breast.
Yep.
And the other piece is if there's not a space for them to stay at the hospital extended, the transport back and forth and being able to have access to a good hospital-grade pump at home can be an issue as well, which I know that OW has some input there to help on.
I wonder if some of that really good data and this isn't in my slides because I just heard about what the data was, but I wonder if we have really good breastfeeding rates locally because we have a methadone program, right? Because if you're a polydrug user, you're not supposed to be able to breastfeed. So if you have cannabis thrown in there, a lot of people would say, well, you're cannabis and methadone now, you can't breastfeed. And that would that's those women who get told that they can't, right? Partly that's where it's coming from, okay? So in Canada, where we have a program like this, we may actually be seeing a lot more because methadone is no longer recognized as something that breastfeeding is contraindicated with. So as you're working with these moms, a lot of what you're doing is you're trying to give them that umbrella. All those potential risks that we've seen on those slides are potentially going to affect them. So we're trying to shield them from that. And a big question in figuring out how to move forward with these moms is really asking yourself the question, how much risk are you willing to take? Okay? Now, as a treating physician, and where I'm the one who's getting asked the question at the end of the day, can the child go home? Can the child not go home? I mean, I'm used to taking some of that risk on. But I'm sure in your particular jobs, whether it's CAS or nursing or whatever, you're asking similar kind of questions. Maybe not in the context of discharge or no discharge, but there's a lot of questions like that where you're having to assume risk. And it makes you feel like crap. These are the things that keep us up at night, right? These are the ones we go home scratching our head and what should I do and I don't know what to do. So, it's always the fine line between taking a calculated risk and doing something dumb, right? None of us like to look dumb, and especially when a kid's safety is involved. So a better way of looking at this risk, and one way of mitigating the risk, is to have more brains with you, right? It's the two brains are better than one, and hopefully when we're working in our multidisciplinary teams, it's not that the more people in the room or the more cooks in the kitchen will spoil the broth, right? You want to make sure that you're an effective, collaborative team that's providing that patient with all that risk, a good circle of care that's going to follow them through time. Okay, and we'll talk about why that time is important. But really, trying to think of this as a team effort becomes very important. And recognizing that your personal beliefs and your personal, how you think about somebody who's been on drugs in their life affects the way that you're dealing with them is very important. Because you can have your own personal feelings when you walk out that door. But when you're on the job, right, we are expected to be professionals and provide these people supports and help and healing. And I think your personal beliefs need to get kind of checked at the door a little bit. And then the legal framework. So if I'm working in Arizona, my approach is totally different, right? If I'm working in New York City, my approach is totally different. Okay? A lot of the states now have legislations with the war on drugs. They've very much criminalized it. So know what your local framework is. So 3 quick cases, and I think I'm not going to belabor the point because it seems like the audience through Dr. Donald's talk is pretty knowledgeable. But 3 cases. So Sue, she's been on MMT for the last year. She has one other 4-year-old child who is in her care. Became pregnant shortly after starting on methadone. Family supports are fair. Father's recently left the picture. Right? So how do you look at that situation? The other person would be somebody like Sarah, who used cocaine, marijuana, and alcohol in her early pregnancy, and then got on the bandwagon later in the pregnancy. She was scared of the prospect of the baby needing to stay in hospital, so she crash-weaned herself, right? And what kind of risks does that pose? What are the kind of situations there? Baby does well after birth, doesn't have withdrawal signs, and now you're at 72 hours, you got to make a decision, right? So, Mary has chronic pain treated with opiates, not methadone, not anything illicit. She had a gallbladder stent, and she needed it for chronic pain. University-educated, well-paying job. She screens positive for opiates and cannabis. What do? Right? And these are all daily situations that we're facing. Now, I find it weird that the one who kind of gets off the easiest, if you look at the protocols side of things, is case 2. Right? Case 2, if the house is deemed fit, she can go ahead, go home, keep breastfeeding, room in with the baby, 3 days, bye, you're gone. Or actually 5 days, right? Because she crash-weaned herself. So 72 hours. Okay? The first case, stable mom, a little bit of issues with family support. She's in hospital depending 2 to 6 weeks, right? And the third case, she's told, nope, you can't breastfeed. Your baby's going to have to go to the NICU. Potentially puts that baby at risk for poor bonding. So it's odd. And I agree, applying guidelines blindly doesn't take into account all these individual factors. And we have to figure out better ways of working within those guidelines. So, what's wrong with this slide? I don't think there's a safety exit. Right? Everything is risk. It's a one-way ticket. It's a matter of how much risk. And what we want to do is promote situations where there's less risk. But it's not a choice between risk or safety. So, any questions? I see one hand there. Yeah.
You mentioned a little earlier withdrawal from things like the SSRI. Are there any protocols for postpartum to those kinds?
Yes. Actually, yes. The provincial guideline covers all drugs. So it's going to be different things that we choose to treat different withdrawals for. But you would use, typically, for most of the opiates, you're using morphine. So paregoric has kind of gone by the wayside. Tincture of morphine has gone by the wayside, mostly because they contain alcohol, is the biggest reason. So we just go with the straight morphine now. The other type of depressants, they used to use a lot of Valium and benzodiazepines, and we don't use those anymore. We go more with phenobarbital. So phenobarbital is the treatment of choice for most other withdrawals. And then you can sometimes use combinations. So certain combination drugs. So morphine, you might use, let's say I have a mom who's very difficult to treat, who's on morphine, who the baby's on morphine, and I'm going up and up on my dose. I can sometimes use clonidine. Clonidine is an adrenaline blocker. So it tends to make, and we use it a lot of times to help adults with their withdrawal symptoms. So it works in a very similar way in the babies. So we might give them morphine with clonidine, or let's say you had a mom who was on methadone and cocaine, which is a common scenario from the data that Dr. Donald showed. You might use morphine with phenobarb, right, to try to manage that child. So there's different combinations that you can use. The SSRIs give you a little bit of different kind of issues too, because they cause some rhythm disturbances in the withdrawal phase. So you do have to have them monitored if they're showing overt signs. And it's probably a group that we're missing a lot, because a lot of the mums come in on Paxil or, all these different kind of things. Right? Makes sense so far? Any other questions? Yeah?
Sorry, I'm not in the medical field, so I'm just wondering if mom and baby are released, say, after the 2-week window that you talked about with prescription for morphine, mom administers that to the child?
Yeah.
And how long does that usually go for?
We can talk about that in a minute. I'd like to get to that in a minute. So, promoting breastfeeding. Okay? This is number one for a reason. Okay? Everything else I'm going to talk about probably has less impact than this one slide. So, the biggest thing you can do to help a mom who's going to have a baby who's at risk for neonatal abstinence is make sure she's breastfeeding.
As long as it's not illegal drugs, though, right?
Correct. Correct and not correct. Okay? The research shows that if the mom is using methadone or if she is a polydrug user, there's lower chance that she'll go into withdrawal. She'll need less medication for the baby, and the baby's length of stay would be shorter. Okay? And that's irrespective of the drug. So that goes into the whole thinking that Dr. Donald said, the baby's been hooked up to a machine that's been pumping whatever drug in, right, for the whole time. And from a simplistic kind of viewpoint, just having her breastfeed and continue that on, it's going to be trace amounts. It's not going to amount to the same kind of doses that she would have gotten in utero. So you can promote breastfeeding and still be okay. What's tweaked about that, and the reason you were right in saying it, is our provincial guideline says if it's a polydrug abuser, you should promote abstinence from the other drug. They can still stay on their methadone, but you should promote that they abstain from that, pump the milk, discard it until they get clean from that, and then you can go ahead with that. Okay? There's still some mixed feelings on it, though. Yeah?
The cases that I've dealt with where there's a baby being born, they usually keep the baby in hospital for 2-3 weeks. But they don't usually keep the mother in the hospital. Am I missing that protocol? I mean, mothers are usually discharged in 3-4 days.
We'll get to that.
But it's in the breastfeeding area.
You're right. But yeah. Now I like trying to make sure that we're promoting breastfeeding. So I saw a mom this morning. First thing I said to her, "Are you breastfeeding?" She says, "Yep." "Has the baby latched in?" "Yep." "Perfect." Okay? That's going to be the number one thing. So, and it can reduce the chance of the baby going into withdrawal. Probably it'll reduce it from 85% down to about 50%. So you're talking a big chunk of change there. Okay? So that's just a graph for those of you who like looking at graphs, but it just shows lower Finnegan scores, quicker reduction. So that's to make me look like an expert. I have to put up at least one graph, right? So this is for breastfeeding moms, 85% would be our entire initiation rate. And this is not Lambton or Kent County or Essex County from what we just heard, because it shows that if you do rooming in, rooming in and then sending them out after 2 weeks to finish off the morphine at home, you get about 25% of moms who will keep breastfeeding. If you keep them in for the full 6 weeks, it drops down to about 7 or 8%. So keeping them in hospital longer tends to work against us for promoting breastfeeding in the mums. A lot of people forget about this point. And I think that this is something where all of you can probably do even more than I can do. All right? We need to be educating these mums about co-sleeping. So this was a study that looked at 1,103 cases of withdrawal in Ontario. Looked at all of the cases and then found who had died. So the kids who died, 6 of them died from sudden infant death, 1 from bathtub drowning, and 1 case was undetermined. And that kid had some cough syrup in his system, so there was some codeine involved, but the kid was being treated for a cold at the time. No cases out of 1,100 cases. Nobody died from the mom giving the kid extra morphine. Okay? So when you're all worried about sending mom home with a couple of doses of morphine, I would say that when you look at the data, they're more likely to drown in their bathtub than they are to get killed by that morphine. Okay? So again, thinking about the kinds of risks, I think trying to educate about co-sleeping, and we already talked a little bit about how mums can get really drowsy. The thought from the corner was that sometimes the mum may take her dose of methadone and then go and sleep with the baby and go into a really deep sleep and not pick up on those cues. The other kind of thing is, if somebody went out on a bender, right? They may roll over onto the baby and suffocate the baby. In this population, a lot of them were co-using oxycodone on top of their methadone, and 50% had used cocaine during the pregnancy. And cocaine use during the pregnancy is particularly bad because it really affects the baby's brain. Okay? Methadone actually doesn't. No difference at all in the kids when they're in school age between the methadone kids and the regular population. Okay? I worry more about the in utero effects of nicotine than I do about the in utero effects of methadone. Okay? Explore the family support system. How are they going to cope when they get home? Fathers, grandparents, friends, professionals. Who do they have coming into the home? Who can help them? I believe firmly, and I will tell you this is a more contentious point locally and provincially. I really am a firm believer in early discharge. A year ago, I did a survey of southwestern Ontario and southern Ontario, and did a survey of all the different NICUs across that area of the province. About 76% of hospitals were sending kids home on morphine, and about 25% weren't. So you have different places that are doing different things. So some hospitals, like St. Thomas, they will not send them home. Chatham, Windsor, they typically would send them home on morphine. Okay? Some places are split. Sarnia, Hamilton. Okay? But a big place like Hamilton, there's not even consensus in that kind of region. And then as you get further to the east, so Kingston will not. And they were one of the main authors on the provincial guideline. So you have big centers, very different kind of philosophies. But in my thinking, right, most of those deaths that we showed, you know how old those kids were? Over 6 months. Nobody under a month died, right? If you look at the patient population, most of the time, 70% of the time, it's going to be cases of neglect. Okay? In the non-neonatal abstinence, they get picked up a little bit later. So a typical neglect case might be 2.5 or 3 years old in the general population. In the methadone population, it gets skewed downwards. But the thinking there is it's not because they're necessarily abusing those kids more, but they're really under the microscope, and they have a lot more community involvement that's looking for it. So we may be picking up those kids earlier and therefore skewing data that way as well. Okay? But I'm a big believer in letting people go home on morphine. And then thinking about what your safety plan for colic is. So Oval doesn't work. Gripe water doesn't work. Probiotics is currently the treatment of choice for colic. Okay? And that's American Academy of Pediatrics statement. Okay? And it's basically a lactobacillus. So it's the same kind of stuff that grows on mom's nipple and the same kind of thing that's typically in like yogurts. Okay? It doesn't need to have acidophilus and all these other kind of added fancy things. What's been studied is the lactobacillus. And there's about 3 or 4 different brands out now. And it'll all be lactobacillus like reuteri or lactobacillus, and they call it something else so that those companies can trademark that particular bacteria. They make sure that there's little things that, it's like the bacteria have a little Coca-Cola logo on them or something so that they can make money off them. But making sure they have good skin care, that you're managing the diarrhea well, all becomes important too. And then I think the biggest thing is the strong follow-up plan, and that's what all of you are doing. Hopefully what I'm doing too. So if I have somebody, I'm going to have typically a kid with neonatal abstinence whose mom was taking methadone will start to show withdrawal in the first 5 days of life. Okay? So during that time, if the scores get high enough and it's not responding to swaddling, darkened room, quiet environment, gentle kind of approach, vertical rocking, okay, not swinging because that's been shown to be overstimulation. So vertical rocking, okay, and all the good stuff that the nurses do in the unit. If they're not doing that, then we start them on morphine. The next 3 to 5 days, usually they're doing stabilization. So that's where you're trying to figure out what the right dose is. Sometimes you got to go up and up and up until you can gradually get those symptoms under control. Okay? So then they cruise there for a couple of days, and then we would start to taper them. And if you're following provincial guidelines, the full taper is probably going to take you somewhere between 3 to 6 weeks. Okay? So, and I should say, by 3 to 6 weeks of age, they'll be off of their morphine. Okay? Now the question of what point in that tapering off you let them go home, some people will opt to keep them in hospital until the last day or a couple of days even after they're off of the morphine. Some people will let them go earlier. Now my feeling, and I'm totally willing, if you guys all think I'm out of my mind for doing this, let me know. But my feeling is a 2 weeks of observing mom interacting with the baby is plenty. Okay? I should be able to make a reasoned decision and know what my general risks will be after 2 weeks. And my personal feeling is that longer than that, I'm not adding a lot to my risk assessment, and I'm putting very I can say from having had a father who just passed away from leukemia and having spent 6 weeks going back and forth to the hospital for him, 6 weeks is a long time. It's a lot of stress on a family. You're dealing with families who are at risk. And in my personal practice, I would let them go earlier than that. Okay? When they go home, if they're on morphine, the provincial recommendation is that they should see a trained physician who's comfortable with managing kids with neonatal abstinence on a weekly basis at minimum. And that they get carries, okay, of no more than 1 week at a time of the baby's medication. Okay? So they're already used to doing that 1 week, right? That's not a big deal. Their dose of methadone is about this much. The total dose of morphine is that much. Okay? Are they going to divert it? I don't think so. Because the stick is that baby is going to wail and scream. I mean, I think it's a bigger risk, and there are some studies that have looked at this, that some of the mums might divert their methadone to the baby. But that risk don't go away magically at the 6 week mark, right? You're still faced with that risk. So in my mind, the risk of diversion is very, very low. The other thing is, again, most of these kids, actually the median time for the neglect was at 1 year old. Right? So if the median time is at 1 year old for cases of neglect, should we be having surveillance systems in place that try to provide them? We're really, really front-loaded, right, in the way that we currently do our follow-up. Should we be rethinking that? Should we be spreading it out over a longer time frame, or having some sort of system in place to really look at them longer term? And then review your results. So I think like a study like Dell's, that's perfect. That's what we want to do. I'm hoping to try to get a chart review done. I've said it for the last few years, but now that things are starting to settle and we're starting to see a consistent kind of practice at our own hospital, now is probably a good time to start looking at the data and seeing, are we making a good decision? But the big thing is, make a decision. Okay? People who sit on the fence don't do well in this, right? And I think I would encourage you all to really think about what you're doing. If you are taking long to make those decisions, from CAS, from the physicians, from the nurses, how it impacts on patient bonding. So somebody asked the question before, how can you manage these people? So I'm going to ask the audience, maybe somebody from Windsor can tell me what Windsor's general practice is for trying to make sure that babies and mums stay bonded through this process. Anybody from Windsor? I can answer if nobody wants to.
No one from Windsor here. They have their own separate kickoff.
So in Windsor, they are relatively plenty in the cash, in that they have care by parent. So they have a unit where they can have the care by parent, and the person can stay 24/7 as long as the kid's in hospital, and that's part of their program. Okay? Now I would say that is exceptional. Okay? The only other places I know that are similar at all might be London, some of the bigger units where they have those kind of facilities available to families. However, the knockoff version of that, I think, is a really, really valid one. So anybody from Chatham? Okay, I think you're doing the knockoff. So why don't you describe what you do?
well, we don't keep babies until they're weaned off of morphine. I would probably say typically, depending on how badly they're withdrawing and how quickly they respond to the morphine and a drop, probably they're 1 to 2 weeks, I would say. Parents are encouraged to come anytime they want. When the baby is doing stable, they can come in and take the baby down to, it's called like an almost home room, where they can go down and spend a day with the baby down there and then come back at night. If we're concerned to see how the parents are going to do with giving the doses of morphine through the night or just total care and how they handle it, then they stay for a day or two in the almost home before they go home, where we can do better observation of how they are on just solely themselves.
Yeah, so I think that's what a lot of places in the province would do, is trying to, as much as you can, figure out worm, squirm, figure out ways to keep mom in hospital as much as you can, and then offer that 48 hours at the end. I think an even better way of doing it, though, is one of the things that they encourage in the guideline paper, and some other hospitals are doing it. They actually will use the pediatric unit as a step down from the NICU. And what that's been shown to do is it helps reduce costs because you're freeing up a higher acuity bed for a sicker patient. And then you can get more weighted cases from that. And you're using a lower acuity bed where you potentially will get the same kind of revenues. You can use your pediatric nursing expertise still, freeing up the NICU beds. And that way, if they're in a pediatric bed, they have the fold-out beds, the mom can stay there 24/7, they can stay there as long as they want. So it really makes a lot of sense. And I think more and more, that's the way different places across the province are going. So Niagara was starting to go that way. Brantford, there's a number of different units that are going that way. So I'm going to stop now because I am a little bit over. But any questions? Any other questions? Yeah.
Have you ever thought about trying antibiotics in the nursery? Sometimes we wonder, after a while, is it the morphine that's upsetting the baby's tummy and their scores are going up? Have you ever thought of trying antibiotics?
I would like to. I know there's good literature to support its use in preemies. It's been used a lot in NICUs. Any kid in my general practice, if I have a kid who's been either on antibiotics in the NICU or who has spent any amount of time in the NICU, they all go on probiotics.
What about your NAS, the children
Yeah,
experiencing NAS?
including my NAS. And the reason is, think about it, they've lived in a sterile environment with nasty bugs, right, that are all antibiotic resistant. They stink. Okay? If you did a smell trial of baby's poop, okay, of a kid who had been rooming in with mom and a kid who had been on antibiotics and in the NICU, and you did a sniff test on the diapers, you would die when you smelled the babies with NAS because they stink. Their bacteria cannot be the same. Okay? And we know that that's actually true. So I think repopulating their gut with the normal bacteria will actually have a bigger effect even than in your general colic population. But that's my personal opinion.
So is it your patient that has you to order probiotics while they're in hospital? Just to see if it makes sense?
I can. The only thing is I can't remember if I need to get it on a hospital formulary to do that or whether the parent can go buy it. Usually it's $25 for a 25-day supply. So it's about $1 a day, and it's like 5 drops. So it's very easy to do. Right in the back.
Do you know if, when you're doing your prenatal appointments, how many doctors or if any doctors screen for drug testing in urine?
I'm not sure how many do routine screening in our obstetrical practice. We try to do 100% of the moms get prenatal consults with pediatricians, most of those mums are through the methadone treatment program, so they're getting routine urine testing through there anyway. The ones who we pick up late, they've usually hidden their pregnancy from anybody they can and show up at the hospital just because they're having the baby. So those ones, we do certain things on the baby to collect urine and meconium, okay? And then if you can't get the meconium, then you can, with consent, clip their hair. And hair and meconium goes back 3 months. So we can tell what the mom's taken for the last 3 months, rather than just using the urine, which goes back for only a week. Okay? The other big factor with meconium, what's really good about the meconium, is you can test for alcohol. And that helps you identify the kid who's also going to be at risk for fetal alcohol syndrome. Because if the fatty acid esters are elevated, which is what they test for at Sick Kids in Toronto when we send it away, if those are elevated, then the child has 40% risk of fetal alcohol. So, having those kinds of pieces of information when you're making risk decisions on eventual child placement and stuff like that becomes very important. Yeah.
I really like the idea of using the pediatric floor and the step down and creating that mom-baby dyad and fostering the bonding. Can you provide, I know that every mom is different, but do we have a length of stay range that the LHIN should be looking at?
Well, depending on whose practice you're doing, if you're doing discharge early, okay, which is the kind of combined care, hospital and community, versus keeping them in hospital alone, the savings per case is $13,850 some dollars. So there are studies out there that have looked at it. The projection with the numbers that we have through the province is that it would save somewhere around $6 million a year for the province if we all adopted that model. However, if you're doing the extended stay, the problem, as far as my understanding goes, is the big problem with the extended stays is all of the case waiting for those cases. So where you're getting your money is early on. And then the case weight drops precipitously, and we get almost no money for the rest of the time they're in hospital. So if they're in there for 6 weeks versus 2 weeks, it costs, we make about the same amount of money in payments from the province, but we've used 3 times the resources, right? So your cost per case goes way up. And I think that's a huge issue. I know that different people in the province are experimenting with different types of protocols to try to see if we can get them out any quicker. I think the big risk is if you drop them too quick. It's kind of like Dr. Donald said. I think if you were to crash wean a baby and then they start to go through subacute withdrawal a month later, because it can take up to 6 months, if they start to become wild and crazy at 3 months old, then you're going to see shaken babies and stuff like that. So that would worry me. But again, and that's my personal feeling. I'm not trying to criticize anybody else's practice.